My most sincere thanks to the organizing committee for kindly inviting me to deliver a talk on whether DK-Crush is the gold standard for complex distal left main stenosis. I have nothing to disclose. A lot of factors may define the complexity of a bifurcation lesion. Until we have the criteria set by the definition studies, no unique definition for a complex bifurcation lesion exists within the literature. In the definition study led by Dr. Chen Xiaoliang, a complex left main distal bifurcation is defined as the presence of one major criteria, including here a side branch diameter stenosis of more than 70% and lesion length, the side branch of more than 10 mm, and the presence of two minor criteria, which may include the presence of more than mild calcifications, multiple lesions, bifurcation angle of less than 45% or more than 70%, main facial reference diameter of less than 2.5 mm, main facial lesion length of more than 25 mm, and thrombus containing lesions. So again, complex bifurcation lesions is the presence of one major, one or two, plus any of the two minors. Complex bifurcation lesions in this study were found to be associated with more adverse events as compared to simple bifurcation lesions, including here higher rates of one-year MACE, cardiac death, myocardial infarction, and stent thrombosis. If we compare two stent strategy as versus a provisional stenting strategy subgroup in this clinical study, in hospital, myocardial infarction and major adverse cardiac events are significantly lower in those undergoing two stent procedures, whereas at 1 year, cardiac death is also significantly lower in those undergoing two stent procedure. Major adverse cardiac events were the same. It is also important to note that the occlusion of the sizable side branch is associated with adverse clinical outcomes, as shown here in the COBIS registry. Increased cardiac death and myocardial infarction, MACE, and also stent thrombosis. We owe a lot to Dr. Chen Xiaoliang for introducing us the DK-Crush stenting technique. I think we all know about these techniques, and this is just to show a picture of that. But nowadays, refined procedures include not only DK-Crush and the necessity of guide wire to cross the proximal side branch, but also pot and repot, kissing balloon dilatations with minimal balloon overlapping, and the use of short balloon for the side branch. And this is the DK-Crush-V randomized trial showing here that in simple lesions and complex lesions, DK-Crush is definitely superior as compared to provisional stenting strategy. The absolute benefit was greater in the more complex lesions here. And another important study is the definition 2 study. They used the same criteria for complex stenosis. And in this study, again, they showed that at 1 year, TLR, target lesion myocardial infarction, and target lesion failure were significantly less than those undergoing DK-Crush as compared to provisional stenting strategy group. Can we compare the result of DK-Crush trials with the EBC MAIN? If we look carefully, then we know that in the DK-Crush trials, a lot more operators are experienced, and the primary endpoint is different, and lesion complexity seems to be worse in the DK-Crush-V, as indicated by higher syntax score and longer side branch lesion length. And upfront two stent strategies are DK-Crush in all here, as compared to pull-out and tap procedures in the EBC MAIN. And crossover to two stent from provisional is 41% as compared to 22. So comparing these two trials are not just comparing apple to apple, but probably apple to orange. I would like to present several case examples where DK-Crush is definitely preferred over provisional stenting strategy. Case number 1, a patient with highly calcified left main bifurcation stenosis as shown here, and also narrow angle between LED and LCX, high syntax score, Euroscore, and NERS score. So this is definitely an indication for DK-Crush. And you'll see here I have to do ROTA and then continued with the DK-Crush procedures. And we obtained excellent final result as shown here. And at 1 year follow-up, there is no restenosis. Case number 2, DK-Crush for very complex, heavily calcified left main bifurcation stenosis and severe triple vessel disease. Again, a patient who has a high PCI and surgical risk. And you'll see here, very nasty looking bifurcation stenosis, diffuse disease in the LED and in the CERC. And of course, after stenting the lesions in the mid and proximal LED and LCX, I embarked on implanting stents with the DK-Crush technique to fix the bifurcation stenosis and obtain an excellent result like this. And this is at 3 years follow-up, no restenosis. Another case example of a patient with double bifurcation stenosis involving LCX and obtuse marginal and also left main bifurcation here. We fixed this with the double DK-Crush technique. And then this is the procedure. We implanted the 2 stents in the left main and obtuse marginal, and also 2 stents in the left main and also LED and also left main LCX with the double DK-Crush procedure and obtain good result like that. And this is at 1 year follow-up, no restenosis. This is another case example of a case with left main trifurcation stenosis. You'll see here the intermediate branch is very important here. And we use DK-Crush to fix these lesions. And then we implanted the stent from the left main to the intermediate branch and then left main to the LED using the DK-Crush technique and obtain excellent final result like that. And this is no restenosis at 1 year follow-up. So in conclusion, the philosophy of making complex matters simple may not be necessarily true for PCI of complex left main bifurcation. DK-Crush and definition 2 study showed that DK-Crush provides better outcome as compared to provisional stenting. Comparing DK-Crush and EBC MAIN is like comparing apple to orange and not apple to apple. An integrated approach that combines careful case selection, proper pre-procedural planning, and specialized technique with adjunctive intracoronary imaging plus or minus functional assessment is likely to further improve the success rate and long-term clinical PCI outcomes of complex left main bifurcation lesion. Thank you.